So, can you just tell me, like the definition of ulcerative colitis, in your terms?
So the definition of ulcerative colitis is a chronic inflammatory condition exclusive to the colon. It's related to an autoimmune problem, meaning that your own body cells attack the colon and produce inflammation. It's a chronic inflammatory condition of the colon, and unfortunately, because it's your own body cells attacking the colon, it's not able to be cured, but it's able to be managed with medications. The only exception to cure would be if someone were to have their whole colon removed during a surgery. That would be a potential cure, but besides that, it's not. But it can be effectively managed with medications.
Okay. The patient of UC that we had spoken to and interviewed, Mario, he described the beginning episodes of having UC as going to the bathroom a lot, having bloody stool. Can you tell me a little bit about the symptoms and kind of those first few episodes?
Sure. So what usually happens with ulcerative colitis is that there are periods when the disease is controlled and punctuated by periods of flare. So during the periods when the disease is controlled, patients may have normal bowel habits without blood or abdominal pain. But during flares, they'll typically have diarrhea anywhere from a few bowel movements to sometimes more than 15 or 20 bowel movements per day, usually loose with blood and with abdominal pain related to the inflammation inside of their colon. And with time or with medical treatment, those flares get better. And the goal with ulcerative colitis is that we give medications that help maintain remission and prevent those periodic flare-ups from occurring.
Okay. Mario said that he had only he was diagnosed in 8th grade. He's now 22, and he said he only had one time where he had remission. That was somewhere in his junior year of high school. And he would flare up like every fall and every spring. Is there like I guess a pattern that develops over time with these flare-ups that you talked about?
There can be triggers. The triggers are not seasonal, but the triggers can be anything from a new medication to a dietary change to a stressor in someone's life, to an acute infection that could occur, to not taking medications for the disease. Those are some of the most common things that can cause flares. But there's not really a seasonal component, meaning that it would happen during certain seasons more than the others in the absence of those other triggers.
Okay, and you mentioned that because if you don't take medication, it can cause, I guess, more pain. He mentioned he didn't take his medications for a period of time because he was kind of, I guess, he wanted to not think about that.
Yeah.
And so what could have happened? What could have happened internally at that period of time when he was not taking his medication? Like, how can it worsen the disease?
So again, it's a chronic inflammatory condition of the colon. So the inflammation will be present depending on the way that your body's immune system is, but pretty consistently. And so the medications help to subside that inflammation. If you don't take the medications, the inflammation in the colon oftentimes will come to the surface and then cause symptoms. So the disease is actually a disease typically of the young, meaning adolescent through early 30s is when the initial diagnosis is made, and then there's a second peak that can occur around the age of 60. But typically it's a disease of the young, and oftentimes young people aren't that comfortable with taking medications, so they often fall off the wagon and miss their medications. There have been studies that have been done that show that patients are sometimes 50% or less compliant with their medications, which is oftentimes what I see in clinical practice.
What are some of the things you tell your patients that come into you to talk, especially younger kids, to kind of like cope and get through this? Because obviously it's hard mentally, and especially when you're going through high school or college.
Yeah. So the most important thing to understand is that we need to keep the disease controlled, and if the disease is controlled, then your quality of life is going to be better. And there are dietary ways to do that. and then there's medication or medical ways to do that. So the while no clear diet has been shown to maintain remission, flares can be brought on by lactose or presence of lactose, because you already have diarrhea and you're adding lactose that causes more diarrhea. So milk, soft cheese, ice cream oftentimes will bring on the symptoms. Some people believe that red meats also may contribute, although that's not as well defined. But definitely having high residue in your diet, meaning high fiber, meaning a lot of uncooked vegetables, having the skin on fruits when you eat them can oftentimes trigger more symptoms. And then medications need to be taken on a regular basis, and there are several different classes with various different levels of effectiveness and toxicities, which is what we spend a lot of time talking to patients about, actually.
Okay. And once a patient has gone through remission, then they go through a flare-up again. How do you determine if a patient's a candidate for surgery?
In the way that, the way that medical management currently exists, surgery is a last resort for ulcerative colitis. We will, for a flare, for instance, we will try medical management that could include steroids, that can include intravenous medications called biologics, and that could even include enemas or suppositories that they use for inflammation that's in the rectum or lower down in the colon. And when we find that the maximal therapy, which usually the steroids and the injection biologic treatments, are not working, we have a surgeon, oftentimes a colorectal surgeon, that's involved, which can discuss surgery with the patient. Usually these are patients who are refractory to medical management or have a very enlarged colon called toxic megacolon, or have a tear within their colon or an obstruction. So those specific cases would be the cases that we would favor doing surgery. In addition, if a patient develops, as a result of this condition, any precancerous or cancerous change, we would also recommend that they have their colon taken out.
Okay, and you mentioned cancer, and you mentioned certain medications. For this specific patient, the doctor recommended Humira.
Okay.
And they said that the possible side effects could be cancerous. And so, could you tell me a little bit more about Humira? What it is, what kind of drug it is, what it can do, what its side effects are, and if you were to have a patient, would you? I guess it would depend on the patient, but would you prefer, that surgery or to, treat them with medication? So you could start by that first half of the question. What is Humira?
Sure. Humira is the brand name for a drug which is called a biologic. It's an injection medication which is a humanized form of an antibody against an inflammatory marker, which prevents this sort of cascade of inflammation from happening in the colon. And it's a medication that a patient, once they're on a steady dose, injects under the skin every 2 weeks. And so it's one of a group of injection medications that we can offer for ulcerative colitis. And so when do we decide that we want to try to treat with medications versus surgery? So medications are usually our first option for treatment of ulcerative colitis, but upfront surgery may be an option for a patient who has very enlarged colon up front, which is in danger of having a tear or puncture. Actually, when there is a puncture in the colon, or when there is precancerous or cancerous change up front, at any point, we would recommend surgery up front. The one thing to consider for surgery, especially for women who have ulcerative colitis, is that it most likely reduces their fertility, and that's an issue amongst young women. So we have to discuss that with them up front and make sure that they're aware that that's a potential side effect. If there are no other options, then of course we will proceed with surgery in that event, and then just sometimes have them speak with a fertility expert beforehand to preserve eggs sometimes, or to do other things to preserve their fertility.
Okay, and you brushed up on this a little bit before, but the surgery in itself, they remove the colon and they create a pouch. In this specific case, he had the procedure done, and I think it was a .001 chance, but there was a knot in his intestines, and so they had to snip each side. Um, can you tell us a little bit about that surgery and I guess summarize what happens in it?
So the surgery, which is the predominant or almost exclusive surgery for ulcerative colitis, is a surgery where the entire colon is taken out because the entire colon is what's involved and what could potentially become inflamed. So no segment of the colon should really be left because any segment of the colon could potentially become inflamed in the future. And then there's a connection that's made between the small intestine and the anus. So the anus is they're connected by creating what's called a pouch or a J pouch, which mimics or creates a reservoir for stool, which is similar to the rectum. It tries to act like a rectum normally would, holding the stool before it's expelled. So that is the surgery. It involves it's a pelvic surgery. In addition to taking out the whole colon, it can be done as a one or multiple stage procedure. As I discussed before, there could be potential fertility impact, especially in women, but in men there can be potential issues with impotence if one of the nerves is affected as well. Following the surgery, as we had discussed, there can be side effects from the surgery. So one of the principal side effects is that pouch that's created can become inflamed, and then they can develop some symptoms similar to what they had with colitis before, but usually much milder. It's called pouchitis. They also, in the immediate postoperative period, all the same complications that happen with any surgery can happen: slowing of the bowels, bowel obstruction, and other complications.
Okay. And I guess do you do research in ulcerative colitis?
Yes, I do.
Okay, so I guess looking towards the future now, what is some of the research you guys are doing here at RWJ and other institutions to maybe find a cure or further the advancement of? Yeah.
Sure. So continuously, people are trying to look to see if there are what are the mechanisms involved in ulcerative colitis, and to determine based on that whether there's better medications that we can use to treat ulcerative colitis. Is there more things that we can do to prevent these flare-ups from occurring? And so some of the studies that we've been involved in here at the Crohn's Colitis Center of New Jersey include looking at patients in terms of these different injection treatments like Humira, and determining if you use them sequentially, Humira versus another one like Remicade or another drug, is it effective when you have to go to that second line drug, and seeing how those studies showed. And it can be effective to use a second line drug, is what we've shown. We've also done large studies looking at whether or not using medications by mouth can help to prevent the colon cancer risk. So medications like one called Asacol, whether taking that medication prevents colon cancer risk as well. And so there have been some conflicting data on that. So it may prevent colon cancer, but that's not been well hashed out.
Okay, and I guess wrapping up here, let's see. He had like a expiratory surgery to see what was wrong with him, because he was throwing up a lot, losing a lot of weight after that first surgery. What is the expiratory surgery? Is it just to go in there and reattach the procedure or the pouch?
So if after the surgery there are complications, like a bowel obstruction or something becomes obstructed and they can't figure out exactly why, then they can go and do an exploration and run the bowel and see exactly if there's any problem anywhere in the small intestine that's remaining, or the pouch site itself. So that would be one possibility. If it was a multi-stage, meaning that there's more than one stage to the procedure, one stage could be removing the colon, the second stage could be creating the pouch. So that is also another possibility.
Okay. And is there anything you wanted to add as far as that you're doing yourself, like work you're doing, you're studying, that you wanted to share in this documentary?
Sure. So with ulcerative colitis, there's a lot of hope for patients. So there are a lot of different drug options. There's lots of emerging drug options. It has been shown that the more effective drug options oftentimes are the intravenous ones. However, the pills by mouth, like Asacol, also are very effective. We've been looking at our experience with the new drugs, like in one drug called Interview, to see what the efficacy of that drug is for the patient population with ulcerative colitis. And it has been good, and the data shows that it is good. So we're hoping to use that drug, which requires a patient to come in for less time, only 30 minutes, and has less side effects than the other traditional drugs like Humira or Remicade. So I think there's a lot of hope and promise for patients who have ulcerative colitis. It can be well managed. It just requires being in sync with your doctor, making regular visits, following your nutrition plan, and being adherent to your medications. Understanding when you're having a flare and trying to treat that flare early to try to prevent the need for surgery down the road.
Okay, thank you so much.
All right, thank you.
That was great.
Yeah, no problem. Sorry.
Just one. Did we get him saying like his name and title in the beginning?
Yeah.
We did. Okay.
No, I did not. I didn't say that yet.
Do you want to just say to Alex,
Yeah.
Okay. My name is Mark Saxena. I'm an assistant professor of medicine at Rutgers Robert Wood Johnson Medical School and a faculty member here at the Crohn's and Colitis Center of New Jersey.
Great. And then the other last thing is, do you want to just go over what was the triggers question? It was like the second or third question.
Oh, we didn't get that full?
Just the train noise was really loud during that one question. So can we just summarize just the triggers, if you could?
Sure.
Wait, let me was it?
Towards the beginning.
Okay.
Yeah, you wanted to know what the triggers are.
Yeah.
So the triggers for ulcerative colitis can be varied. They can include anything beginning from dietary indiscretions, including the consumption of milk products, of a high-fiber diet, medications, including taking anti-inflammatory medications or not complying with your medications, can include infections, so having a bacterial infection or a gastroenteritis can cause those symptoms as well, and life stressors. So sometimes flares will occur when there's life stress going on, and there can actually be superimposed what's called irritable bowel on top of inflammatory bowel disease or ulcerative colitis. So those are typically the things that trigger the disease, and once those triggers occur, depending on the severity of the ensuing flare, depends on how aggressively we really treat it.
Okay, and actually, I just missed something.
Mm-hmm.
He mentioned that he was taking around 17 pills a day for treatment. Can you, I guess, talk about a few of those medications and what they do, I guess, and their purpose?
Sure. So there are several different classes of medications for ulcerative colitis. Traditionally it had been described as a pyramid. This sort of model is going out of favor, but it helps to describe simply kind of what the medications are. So at the on the very bottom of the pyramid is the core of medications for ulcerative colitis, which are called 5-aminosalicylates. So those medications are usually of two names, either mesalamine or sulfasalazine. So these drugs require taking a lot of pills typically, and these are oftentimes the medications that keep you in remission, but also can be used for periodic flare-ups if they're mild or moderate. The next step up from that would be drugs that change or modulate the immune system. The principal drug would be something called mercaptopurine. It's a pill that essentially changes the way that your DNA synthesizes and helps that autoimmune attack on the colon. It requires regular blood work done at least every 1 to 2 months, looking for different toxicities from that drug. Steroids can also always be used, typically for a flare and short term, to prevent all of the different side effects that can happen from steroids, usually given over anywhere from 1 to 3 month period while other medications are working. And the third class of medications are called injection medications or biologics, which include the ones we've discussed before: Remicade, Humira, Interview, and another drug called Simponi. These are medications which are injections, either taken under the skin at home or with a visiting nurse, or coming to an infusion suite and getting an injection every several weeks or several months to induce or maintain remission.
Okay. And steroids, they're a bad thing, right? I mean, to take in like lots of times, like, right?
So steroids for ulcerative colitis can be both your best friend and your worst enemy. So there are lots of benefits to taking steroids. So steroids will make a patient who's having a flare many times feel great and put them in remission. But long-term use of steroids should be avoided because there are numerous side effects from steroids. They can do anything from cause high blood pressure, weight gain, acne, cardiovascular complications, to a variety of different complications related to steroids, such as raising your blood sugar, diabetes with long-term use, thinning of the bones. And so whenever we put a patient with ulcerative colitis on steroids, we should have an exit strategy which helps us to get the patient off of steroids and get them on some of the other classes of medications that I mentioned before to keep them in remission.
Okay. Great answers.
Okay.
Great answers. Really appreciate
Oh, wait, I had a question really quick. Is there or actually you should probably look at him. Is there a generic brand medications versus name brand medications and cost differences between those? Have patients ever had to choose between a generic and a name brand medication? And what's the effect if they have to do that?
There are generics and brand names for many of the drugs in ulcerative colitis. However, in its current state, the pharmaceutical companies have branded many of these medications, and so a lot of them are difficult to get if you do not have insurance. A couple of exceptions would be a drug called sulfasalazine or balsalazide in that 5-aminosalicylate group, and then azathioprine in the immune modulating group. Besides that, the more potent, and steroids, of course, there would be generic. But the injection treatments, none of the injection treatments, which are the most potent and deemed to be the most effective, are generic. So they cost thousands and thousands of dollars and need to be pre-authorized by your insurance company. And so it's important that patients who have ulcerative colitis maintain their medical insurance so that they're able to get these medications, because pretty much across the board insurance companies will cover them, but you need to have insurance because it cannot be paid for out of pocket.
Yeah, well, insurance it's another thing, but
yeah.
Do you have any knowledge of the insurance stuff here at Robert Wood Johnson, at least, or because there was and at least our story, there was a problem with that, and he wasn't able to get the surgery for a while because of insurance purposes.
Yeah.
Do you have do you know how much the surgery would cost or anything like that?
It really depends on the specific surgery, but any surgery would cost anywhere from $5,000 to $10,000 and above, because there is the facility fee of being in the hospital, plus the surgeon's fee, plus the operating room fee, plus for most surgery there's a hospital stay as well afterwards, and all the fees that go along with hospital stays, which are very expensive. It's hard to say, but it would be more than a few $1,000s. Yeah.
Okay.
Yeah.
Thank you.
Okay, no problem.
Is that it? You good?
Yeah, I think so. I
You have
mean,
anything else?
Sounded pretty good.
I think
I covered everything.
I heard some definitely really usable stuff in there.
Okay,
so
cool.
that's